Is Dr. Sri Likhitha Goli here? Yeah. She will be presenting Cogan Rees syndrome case report.
Good morning to everyone. Today I am going to discuss about Cogan-Rees syndrome.
Please go slow, yeah? Please go, we have a lot of time. Actually, they have given us only 11 cases each 4 minutes, so they have given 75-minute session. So you can take your time.
Okay.
Yeah, please explain everything, be peaceful.
Cogan-Rees syndrome is a type of ICE syndrome, which is a progressive clinical spectrum of corneal endothelial abnormalities, which is affecting the cornea, iris, and iridocorneal angle. There are 3 clinical variations which are recognized. Those are essential iris atrophy, Chandler syndrome, and Cogan-Rees syndrome. It is often associated with secondary glaucoma, which is due to obstruction of trabecular meshwork in the iridocorneal angle, the formation of peripheral anterior synechiae, or both can happen. Vision loss is typically due to progression of secondary glaucoma and corneal decompensation. Here is my case of 20-year-old female patient who noticed an abnormal appearance of pupil in her left eye, which is enlarged and shifted downward, and it is gradually progressive since 5 years. And she also noticed diminution of vision for distance since 5 years, which is insidious in onset and gradually progressive. She has no other complaints of pain, redness, watering, photophobia, trauma, or other laser procedures to her eye, intraocular surgery, and similar appearance in the other eye. Coming to the ocular examination, her vision was 6/6 in both eyes with a refraction of minus 0.5 diopter spherical in right eye and minus 0.5 diopter spherical and minus 0.25 diopter cylindrical in her left eye. And NCT is normal and CCT is somewhat towards the lower side. Pupils are, left eye pupil is displaced downwards, which is mid-dilated and irregular. Pupillary reaction, it is sluggish in the left eye. Ocular movements are full and free in all gazes. Coming to the slit lamp examination, right eye is normal. Left eye anterior chamber is shallow, mainly at the peripheries, with iridocorneal touch, which is present from 1 o'clock to 2 o'clock and from 7 o'clock to 9 o'clock. Pupil is inferiorly displaced and full thickness iris hole is present at 2 o'clock, which is surrounded by iris atrophy. And iris atrophy is present at 1 o'clock. And this is the magnified view of the iris, which is showing loss of normal iris pattern and with ectropia on uvea from 2 o'clock to 11 o'clock, and multiple pigmented pedunculated nodules are present superior-nasally and inferior-temporally. Gonioscopy shows peripheral anterior synechiae in 2 quadrants. Coming to the fundus examination is normal with normal CD ratio, and perimetry is normal, and ONH and RNFL analysis shows no thinning, and which is normal. And ASOCT shows multiple anterior pedunculated iris nodules with underlying stromal thinning and iris adhesion to the corneal endothelium. My provisional diagnosis is left eye Cogan-Rees syndrome with primary angle closure, and differential diagnosis for this multiple pigmented iris nodules include Lish nodules, diffuse malignant melanoma, iris mammillomatosis of oculodermal melanocytosis, inflammatory nodules associated with granulomatous uveitis, metastatic seedlings. Management, we have done an angle closure provocative test in which we have, there is no increase in IOP. So we have kept patient for regular follow-up for every 3 months, and we have given her glasses. Discussion, Cogan-Rees syndrome is popularly called as Innes reverse syndrome, present with a myriad of manifestations such as peripheral anterior synechiae, loss of iris crypts, fine iris nodules, ectropia on uvea, irregular pupil counter, and corneal edema and iridocorneal angle abnormalities and secondary glaucoma. The characteristic iris nodules arises due to pinching of iris stroma by the overlying aberrant translucent endothelial membrane. Multiple delayed peripheral anterior synechiae extend in all directions and may block the angle of anterior chamber. It is believed that glaucoma is caused by the proliferation of corneal endothelium with the formation of a membrane that progressively covers the trabecular meshwork and not due to the gonial synechiae that emerge lately. The present case has loss of normal iris pattern, iris atrophy present at 1 o'clock position, ectropia uvea is present from 2 to 11 o'clock position, multiple pigmented pedunculated nodules are present superior nasally and inferotemporally. Medical management, there is no therapy available which targets the pathogenesis of ICE syndrome. Topical anti-glaucoma medications are usually the first line of treatment for raised IOP, which is not seen in my case. And hypertonic saline is used to reduce the corneal edema. Surgical management includes, if there is a glaucoma, trabeculectomy can be done with antifibrotics and drainage devices. And maintaining long-term success is challenging as fistula and trabecular meshwork can be obstructed with advancing abnormal endothelial cells. Cornea, in advanced cases, if there is a corneal edema, we can manage with penetrating keratoplasty, DSAC and DMAC. Conclusion, to conclude, Cogan-Rees syndrome presents with myriad of iris manifestation and features of glaucoma with unclear pathogenesis. The present case features the occurrence of characteristic iris nodules along with ectropia uvea and peripheral anterior synechiae. These are my references. Thank you.
Thank you, Dr. Likhitha. It was a nice presentation. So for the audience, like we saw subsequently a case of Chandler syndrome with the endothelial growth requiring intervention, and that was managed well with the AGV. And in this case, since all the parameters were within normal limits, the patient was under observation. So, and Dr. Likhitha nicely discussed the differential diagnosis about different forms of iris nodules, and thank you. It was a nice